Thank you for your interest for coming to my presentation. As Kowe introduced, this is really part of my research mission, to contribute to the health management issue among homeless population. It's because I worked as a pediatrician back in Japan. I'm especially interested in maternal and child health. And so I really appreciate this funding opportunity to make a first step to do this analysis. So here's the outline for today's presentation. I will talk background, especially some epidemiological background, and then after that is kind of very routine presentation. So homeless health first. The statistics in 2022 just released in January, and we have about 582,000 people experiencing homelessness in this country. And you could imagine that they have high odds of unmet medical needs, especially related to chronic disease compared to housed individuals. And for especially for the postpartum or pregnant and postpartum women, limited preventive care and poor nutrition and inadequate access to prenatal care contribute to the development of gestational diabetes and type 2 diabetes. So among people experiencing homelessness in 2022, about 40% are female, and infancy is actually the age at which a person is most likely to experience homelessness in this country. And infants are usually accompanied by, this infant is not, it's excluding the one who go to foster care. So those infants are usually accompanied by their mothers. So this is statistics tell us that women in postpartum period are also at high risk of homelessness. So CDC, based on the CDC report, 4% of mothers experiencing homelessness during pregnancy. And pregnancy increases the risk of homelessness, and homelessness also increases the risk of pregnancy. Higher rates of unintended pregnancies also reported, like 73% of homelessness indicated that the pregnancy was unintended, compared to 49 in housed population. So this is not specifically for the homeless women. It's just a general female population. So women with history of GDM, gestational diabetes, have about 10 times higher risk of developing type 2 diabetes than women with no history of GDM. So GDM can be kind of screening for the future type 2 diabetes. So we can provide early intervention by detecting GDM. And so it's recommended that women with GDM have the OGTT between 4 and 12 weeks postpartum. However, the screening rate is historically low, and many smart people develop the interventions, great interventions, and it's but still not very effective. The screening rate is very low. So these are again for general population. Common barrier to the screening is like cost, access to care, poor communication with healthcare professionals. And those are also key barriers that prevent the homeless population from seeking general preventive care. So so it's easy to imagine that homeless women particularly have low rate of postpartum screening compared to housed population. And they are very unique population. They're facing two unique challenges. So the things I have in my mind, always have in my mind, is that the intervention really needs to be tailored to their unique challenges. And again, interventions exist, but it's not targeted to homeless population. And then to develop this project, I thought that maybe I have to have some crazy idea that people never tried. And then that was to use this utilization of healthcare. Homeless population has a high rate of emergency department visit, and actually the hospitalization is higher. But actually, for this particular population, postpartum women, they actually have lower rates of postpartum readmission. That's also one of my projects that I'm working on. But at least they come back to the healthcare facilities for some reason, and then we can do something when they come back to the healthcare. And so then I define any utilization of healthcare as inpatient care, emergency department visit, and outpatient visit for any reason, and then maybe we can do something. Advantages is that because they're people already there, so physical barriers to healthcare access are removed. So they're there, and it's an opportunity for healthcare providers and social workers to talk to them and talk about GDM. And also we can discuss the insurance eligibility and the coverage for the screening, because that's also one of the thing that they're worried, and then they don't have that screening. And disadvantage is to use this healthcare utilization for any reason is that OGTT requires the fasting from the night before, so we cannot do OGTT. And then I thought, can we just use random plasma glucose and in hemoglobin A1c tests? I'm aware this is not perfect, but it's not. It's better than nothing. And then I was doing some literature review and trying to look for some like sensitivity and like false positive rate and false negative rate. And then I found out that Japanese Society of Diabetes and Pregnancy already started to use the random plasma glucose and hemoglobin A1c as the routine postpartum glucose screening. I found out while I'm doing the literature review. So I was so lucky that people already published the sensitivity and specificity and all the values that I would need, not all, most of the values that I would need to do the analysis. Of course, the body mass index is very different between Japanese and American, but again, it's better than nothing. And then I also thought, okay, this is not a crazy idea. People already using it. And also this is not targeting this Japanese modification is not targeted to homeless population. It's for everyone, just to reduce the risk of COVID infection so that the woman wouldn't need to stay in the hospital for 2 hours. They just have the blood test and they can go home. So then I came up, so I planned this project. So first aim is to just estimate the GDM in postpartum glucose screening rate among homeless population. Homeless population is really under-researched population. I think I can talk about that a little more later. But first, I have to show that GDM rate is high among homeless population, and then also the screening rate is low. So I have to show like we have to do something, and we have to provide the evidence. So that's really the first step, because nobody reported the rates. This is a very descriptive, but it's important step for me, or to contribute to the health issues among homeless population. So, I mean, our hypothesis is that rate of GDM is higher and rate of postpartum glucose screening is lower among homeless women than housed women. And then the second aim is to estimate the cost effectiveness of providing random plasma glucose tests and hemoglobin A1c test during any healthcare utilization for homeless women with GDM who miss the recommended glucose screening. So I'll compare the outcome with the current standard of care, which is to do the OGTT. So we have to ask them to come back to do the OGTT. And then my strategy is to use this Japanese modification, which provide the random glucose tests in hemoglobin A1c test when they come back for any reason, come back to the healthcare facility for any reason. Then my hypothesis is that this modified protocol will be a cost-effective strategy for early identification of high-risk individuals. For this study, I chose these 5 states. So first, we contacted 17 states who had female homeless population greater than 3,000 based on the HUD statistics. And then cohort selection was based on data availability. So I have to contact Medicaid, sometimes actually all payers claims data, which include Medicaid and the private insurance. But based on my preliminary results, I have the statistics showing that more than 75% of homeless women who delivered baby had Medicaid. So if we have the Medicaid data, we have cover most of the homeless population. So we first contacted Medicaid, and then also homeless management information system that has the data for individuals who use the shelters within the states. So this is actually not for the research use, this is really for administrative purposes. So I contact them and explain what I'm trying to do. In some states, like Colorado and also New Jersey, they already, and also Arizona, they have used the database from homeless management information system for research. But for most of the states, they have never used it for research. And also, actually, some states, they don't release the data to the researcher, especially outside of the states. Our local states, California, they actually started the data release last year. So we contacted them and asked if we can link the data with the Medicaid, but they haven't established the data use agreement yet. So we're still discussing it, but yeah, we are hoping that we can also use our local data. But for now, I chose this 5 states. And again, data quality is also the issue, and length of time to have the access is an issue. Some states already said that, like among the 70 states I contacted, some states said that it will take like 18 months to get the data at least. because this is a 2-year project. So I eliminated those states, and especially those 5 states. People respond quickly, so that's also one of the reasons I use these states to finish the project within 2 years. Again, I have to contact Medicaid, Homeless Management Information System, and also birth records. Birth records is actually important for many reasons. Birth records has some information for social determinant of health, such as education level, and also marital status, whether they're married or single or divorced. We have that information. And another information I needed from birth record is the delivery date. That's actually not possible to identify with the Medicaid claims data, especially for the ones who had vaginal delivery. For the ones who have cesarean section, we can identify with the procedure date, but for vaginal delivery, we have to rely on the birth records. So those 3 parties within the states all need to be interested in my research. Then we have these 5 states. So Arizona, North Carolina, New Jersey are from Medicaid, and these 2 states, Colorado and Oregon, are from APCD. And again, those states are all very cooperative. And I requested, so I started the data request, of course, in 2013 and 2020 are chosen for this analysis because of the data availability. So the linkage is actually the problem as well. So linkage needs to be performed using personal information like social security number, name, and birth dates. And it's actually, so then they do not want to release the data to me, of course, and I do not want to have those sensitive information either. So we agree that they will do the linkage on their end. And so again, it's a 3 data set: Medicaid, HMIS, and birth records. And so each state have a different organization to link the data. And so then they link the data, or actually, it's not, they just don't have the one data set. They have, each state has different procedures, but the database we received from Colorado, they link the data, meaning that the same individual have the same ID. So when they generate the encrypted ID to identify the individual, they have the name, a social security number, and a birth date, and then generate the encrypted ID, and then they send the data to me without those sensitive information. So I can identify the individual across the database. So that's again, all 3 parties needs to, I have to ask them work together. So it's 3 outside of my control, but they're very nice and they're very cooperative. Yes, it takes time, but we're making progress. So this is my selling point, innovation. This will be the first multi-state study to link medical and homeless management information system, Medicaid and HMIS records to identify homeless individuals. So first, when I first started, I used the records from the hospital records, and some records has the variable indicating homeless. That's just the 0-1 variable. And I have a few publications using the state data from New York, because they have the homeless variable, but I always have that comment saying how was the homeless individual defined, and I do not have the control. I do not know how the hospital define a homeless individual. For example, for some hospital, they define homeless as the individual who sleep on the street. Some hospital define homeless individual as the one who are in the shelters. Some hospital also can include individual who are like doubling up. Yes, I contacted some hospitals and asked how they define the homeless individual, but they do not have the clear answer. And I always have that question. And also, of course, for myself, and see how can I do like a research with a good quality of data. And then I found this homeless management information system. Yes, some again researcher from New Jersey, researcher from like Massachusetts. We couldn't include Massachusetts for this study, but some people, some scholars have used the Medicaid and HMIS to identify homeless individuals, and at least this is not the perfect, but at least we can have a consistent definition of individual who are experiencing homelessness. And then I try to collect the data from many states. Again, my training is to use the administrative data set and using different kind of data set, and I try to minimize the bias. So I thought this is a good way to use my training. And then I contacted 17 states, and it's very hard. But again, these 5 states agreed to participate in the study. And actually, I'll talk about it a little later, but another states, Michigan also now interested, and now we're working with them now to get the data. So this is, sorry, I'm going to a little non-scientific part, but it's very, very, I'm devoting a lot of my time just to get the data, but it's a really important step for this study. And it doesn't look like I'm making good progress, but in my mind, I'm making really good progress, and I'm trying to get the data, and I'm hoping that I can provide a good data by the end of this project. So consistent definition is definitely the innovation, and also from the multiple states. And again, it's a very under-researched population. So we have the first US-based estimate for GDM and PGI, postpartum glucose screening among homeless women. And we also try to we'll evaluate the lifelong effects of the modification of the postpartum glucose screening. So I will talk a little bit about the preliminary data. We were able to receive the database from Colorado, linked database between Medicaid and HMS, and actually with the birth records. So we have this many, a little more than 1,000 homeless individuals in a little more than 187,000 housed population, delivered babies between these 3 years. We identified this 83 homeless in this many house women with GDM. So what we do is that first we identify the women who delivered babies using the Medicaid, and we examine their medical records during their pregnancy. During pregnancy will be the pregnancy period will be identified from the birth records based on the gestational week at birth of the infant. And we looked at their medical records and see if they have GDM diagnosis at any point during the pregnancy. So again, I'm affiliated with the Harbor-UCLA Medical Center, which also serve homeless population. And we experienced sometimes, many times, that homeless women never had any prenatal care and they just come to the hospital for delivery. I'm glad at least they come to the hospital, so they sometimes don't have any prenatal records. In that case, we have to rely on the records at the delivery. So that means that this number is really underestimated. But again, it's so the very first estimate that we're showing to the world. So this rate is adjusted for age, race, and ethnicity, and we see higher rates of GDM among homeless population. It's not significantly. We did not see the significant difference. So once we increase the sample size, we might see some different results. I will continue that. And also, I have to include more adjustment variable into the model. So here's the descriptive table. We see homeless women are younger than housed population. Racial composition is very different, but that's just a different. It's a difference between homeless and housed population. And we also looked at postpartum checkup, and it's actually homeless has a higher rate than housed population. I have to look more. I have to do more detailed analysis why this is happening. Another thing, going off a little bit, but again, we also identify that homeless women had lower postpartum readmission, and many of the postpartum readmission can be prevented if the women had the adequate outpatient care. So maybe they are more likely to come back to the healthcare facility during postpartum. That's why they showed a lower postpartum readmission. So that this is actually supporting my different project showing the lower rate of postpartum readmission. I'm trying to say that this is not likely the mistake. This really consistent with the results that I'm also working on. So identification of patients. In this study, we identified women who delivered babies between this period 2014 and 2019 and examine their healthcare utilization within 1 year after the delivery. I'm trying to show here. So this is the delivery. So we identify women who delivered babies between this 2014 and 2019, and I'll go back 1 year, about 1 year. It's again based on the gestational week. We'll go back about 1 year, and then also examine the records for 1 year after that. So the latest we would need the medical records that we would need is December 2020 for the one who delivered baby in December 2019. So the point is that I have the data between 2013 and 2020, but I cannot include the one who delivered babies in 2020 because I do not have the records 1 year after the delivery. So I have to limit the cohort to the women who delivered babies in 2019. And going back to the records for 1 year also limits the year to 2014, because if I include the woman who delivered babies in 2013, I might not have the full records of the pregnancy. So I limit the records between 2014 and 19. So this is explaining that. So delivery will be identified using this ICD-9 code and also ICD-10 code, and also both diagnostic and procedure code. There's an existing evidence that a validated method to identify a woman who delivered baby using this code. So exposure variable of interest is homelessness. So we define individual who stayed in shelters at least one time during the observation period. So individual who never used shelters and had valid zip code for the home address will be defined as housed individuals. So the reason is majority of women will not use the shelters. So if women use the shelters, that means they are facing to the housing insecurity. So again, this is not the perfect definition again, but at least we will identify the women who are facing housing insecurity. So this is also, I'm trying to explain that homeless women, the women who are experiencing homelessness, it can be time varying situation. Like at some point, this woman is not homeless, and at some point, the same person is not homeless. But at least, okay, majority of the women do not utilize shelters. So using shelter means that that individual is a very high risk population. So I included all of them. I define all of them as homeless individuals. Outcome is GDM, prevalence of GDM will be identified as this ICD-9 code and ICD-10 code. And of course, if somebody has existing diabetes, code for diabetes, existing diabetes, then even though they have these code for GDM, we did not identify them as having GDM. Postpartum glucose screening rate is this different code, CPT code. I listed a specific code for glucose tests and also this fasting tests. So secondary outcome is glucose intolerance at postpartum. They also have the diagnostic code, and we also identify how many has the DM for just the background information. Again, they will not be defined as the woman who had GDM. So sorry, the table is a little small, but these adjustment variables are very typical adjustment variables that many people use, like age, race, and the length of homelessness is also unique to our study, because we can identify the length from the HMIS records. In clinical factors, we can include body mass index from birth records. Insulin use will be identified from Medicaid, but I'm learning that the code for insulin use is not really consistent. I'm still validating using the data we have. Might not be able to use that. Maternal comorbidity index, there's also validated method to identify the index. And hospital characteristics and also geographic location, meaning state, will be included as an adjustment variable. So statistical analysis for AIM-1 is a very typical descriptive, just a very descriptive study. We just identify the women who deliver babies and also identify the women who have the GDM code and the PGS code, PGS, postpartum glucose test. So I will use the logistic regression to evaluate the association between homelessness and each outcome. And then also this will generate the adjusted rates that I showed in the previous slides. So AIM-2 is cost effectiveness analysis. So I estimated that 30,000 postpartum homeless women have GDM. I also stated in the application that this is actually not a really big population, but this postpartum glucose test screening test is lower among housed population. So if this can be successful to among homeless population, we may be able to apply that strategy to the vulnerable population, housed population. So we want to use this as like the first step to evaluate this, whether to evaluate whether this strategy works in this vulnerable population. So this, my intention for this slide is to explain what's happening right now. So now, let's say some woman has, this is like a population based figure, so many women with GDM, and some people have OGTT, and then some have normal test, normal results, and some women will have abnormal results, and then the ones who have abnormal results, they will start to have the intervention, and then the intervention will slow down the development of type 2 diabetes or prevent to develop the type 2 diabetes. And then many actually do not have OGTT, so that's the end for them. If they don't have it, they could go to the intervention, but they wouldn't because they just don't come back. And then so the idea is, can we add the next net to identify women who would need the intervention? So for the ones who did not have OGTT, when they come back to the healthcare facility, we will. So for this branch, the woman who only come back to the healthcare facility can go to this branch, and of course the ones who do not come back to the healthcare facility, they just go there, and I cannot save them. But at least if somebody comes back, I can, not me, but the world can do something, and then do this. I call it Japanese modification, just because it's easy to say. It means random glucose test and hemoglobin A1c test. So they do that, and they, for the woman who has normal results, then okay, that's it. And then for the ones who have abnormal test, they have the OGTT as the confirmation test. And then if they have the abnormal results, we'll have like a very active outreach, and then try to include them as an intervention. That's my dream to do, but I want to do this, but first I have to say, okay, this is cost-effective approach, not just helping people. I have to show that this also save the cost, because we just don't let the people who need the intervention we don't leave them alone. We'll try to intervene and then try to keep help them healthy. So that's my goal. So these are, so I'm talking 40 minutes already, so just skip, just quickly talk about this, but these are really just the typical cost-effective, the procedure for the cost-effectiveness analysis. We'll look at like a quality adjusted life years, meaning that I will look at until they die. And then, so we'll see cost-effective, incremental cost-effective ratio, ICER, with this. And we also need to consider how many people will have OGTT. So I have this step, because the random glucose test in a hemoglobin A1c test cannot be the, cannot confirm the glucose intolerance. We have to have OGTT. But at this point, we can limit the people who need like active outreach. So at least I can save the money at this point. There are many points that I can save some money rather than just not having this and have the active outreach. I still have the screening to limit to have the outreach. And we also, so again, we have to have OGTT, and we also have to estimate how many people will stay in an intervention. So there's a existing literature focusing on homeless population, and actually more than 80% of people staying in the intervention as planned. So so at this point, my assumption is that if somebody was told that they have some health issues, you don't look like you have health issues, but this needs some intervention, then they're likely to stay in intervention. Again, this is assumption, and I have to do some like a qualitative research to really examine what's happening. So there's those are actually the previous slide is something that I need to do as the next step, but there are also some estimates that I can estimate from the database that I'm receiving for this project. And also there's some, so those are especially the ones I can estimate from the database we'll have. And this is particularly important, again, because it's a under-researched population. There's no data, existing data. And I'm hoping that like reporting this rates, some other people also use this rates and do some other study to contribute the this health in this population. This sensitivity analysis is also the very typical procedure for the cost-effective analysis. Actually, the point is that some estimates that I can estimate from the data from the data I receive, but again, it's limited to the 5 states. Actually, could be 6 states. 5, 6 states, so it cannot be generalizable to other parts of the country. So I have to have some like range of like uncertainty and see how the results will change if the estimate I have is not really true. So we'll have the range and see how the result change, and that's the sensitivity analysis that I will planning. So these are the limitations. Yes, I have many limitations, but I just put like major limitation here. Definitely the definition of homeless is the limitation. Could be some could be still on the street. But I have some estimates saying that 80% of homeless population in the states included in the study are sheltered. So I would be able to identify majority of the postpartum woman or the woman who delivered babies. And so again, usually when the woman comes to the hospital, especially the safety net hospital, we talk to them and ask about the living conditions, and sometimes we identify that they do not have like stable housing, and then we usually connect them with the social services, and then they go to the it's very unlikely that pregnant women sleep on the street, and then they usually connect to the social services. So this 80% means like female general population. So if we limit to the pregnant woman or postpartum woman, the rate will be higher than this. So the point is that this is not very perfect procedure to identify the women experiencing homelessness, but we should be able to identify majority of the women. So the analysis only includes just less than 10% of the homeless population. So the generalizability is not really perfect. But again, it's very under-researched population, and I'm hoping that this results will encourage other states to do the linkage or use the data from HMIS for the research. So this is a quick report of my progress. Arizona, I completed all the DUAs, completed DUA data use agreement with HMIS, vital statistics for birth records in Medicaid. So just a few days ago, data from HMIS was transferred to Arizona State University, who will do the linkage for us. Colorado database we already obtained. North Carolina, there are actually 2 HMIS we're still working on. So I was able to have a DUA from one of the HMIS, but I'm still working on with the other HMIS. New Jersey is still working on DUA. So Oregon will the database will be obtained from APCD, but HMIS and APCD and the vital statistics working together. But HMIS is a little new, and they want to. They are working on DUA now, and APCD wants to wait for them for their DUA. So we're still waiting. And Michigan expressed their interest, so we started the data requests. They all agree. HMIS, Medicaid, and the vital statistics all agree to participate in the study. So we started to work on data requests. So as a future direction, I would like to test whether different approach will be more effective. So I found the literature saying that especially for vulnerable population, OGTT during the delivery hospitalization, people usually say 95% of the patients stay in the hospital for 2 days after the delivery. So maybe we can do OGTT before they discharge. I actually wanted to include that in the application, but my co-investigator actually did not like that idea. So I said, maybe in the future, I will do more study and I will include that in the future. And I also want to do some qualitative research, like qualitative interview with women, of course, and also some like social workers, and see the real problem with the postpartum care. So this approach could be applied to other health conditions. We are particularly interested in diabetic retinopathy screening. That we say that maybe when they come, that any homeless individuals who came back to the healthcare for any reasons, again, maybe we can do some quick screening. There's some technology to do the screening very quickly. It's just a screening test. But that this approach could be applied to any some other conditions. I would like to work on that as well. That was the last slides. Again, thank you so much for your interest. I would like to take any comments or suggestions or questions.
Okay, thank you, Rie. So now is our Q&A session. So you can unmute yourself if you have any question, and also you can use chat function if you have any question. So let me see. While during a presentation, there's somebody left a question in the chat. So what will you do if you cannot collect the data in a timely manner since you're collecting the data set from multiple sources?
Yes, that's really, I'm facing to that problem. Like, so one of the HMS in North Carolina, it's taking really long time. In Oregon, they responded, starting to work is it's already February, and the first year and the first year we only have 4 months. And then so we are contacting other states, like Michigan is the so Michigan, when I apply for the grant, they're not interested. It's not really interested. They didn't respond, but now they're responding really quickly, and it's actually moving faster than other states. So I might, so I'm also contacting other states and then see the possibility of collecting the data from other states.
Okay, thank you. So the second question is, people who are coaching, serving, or doubling up will not be categorized as homeless population. How do you address that part?
So that's definitely one of the limitations for this study. I cannot identify them. But again, when some they are likely to go to the safety net hospital, and we ask their living conditions, and they usually, if they're couch surfing and doubling up. Actually, for some cultures, doubling up, that it's not considered as facing to the housing insecurity because they just live together. But if the living condition is not properly for postpartum women and new babies, then we usually connect them with the social services, and then they will be able to, it's based on the availability, but they usually go to the shelters. So we believe that using the shelter services to identify the homeless population, should be able to identify the majority, and they might be categorized as housed population, but that misclassification, the bias from that misclassification is toward the null, meaning that the results we present actually, the true effect is actually larger than our report. And we still definitely the limitation. That's definitely limitation of the study.
Okay, thank you. Any more questions from the audience? Okay. Right now I don't. Oh, hi. Yeah.
Thank you for the nice talks. My name is Jun Ha, Howard University. So as you mentioned several times, it's not better than nothing, but there's still the huge discrepancy between diagnostic criteria between specifically 2-hour glucose and A1c. When especially in pre-diabetes, those discrepancies, degree of discrepancies is really wide. So do you have any plan to kind of estimate or assess those discrepancy in your study?
I'm sorry, discrepancy between what?
Between A1c and random glucose plus A1c. I mean, 2-hour glucose, OGTT and random glucose plus A1c.
Oh, okay. Yes, so that's the results from A1c and the random glucose test cannot be the confirmations. So I still need to do the OGTT after we identify the individual using these screening tests. And so the random glucose test and hemoglobin A1c will not confirm the individual with glucose intolerance. This is really the screening, and that's to identify the individual who needs really active outreach.
Okay, thank you.
Yeah, thank you for the question.